Pediatric Grand Rounds. If I could remind you to please scan the QR code on the sheet of paper on the desk here and log in. Even if you're not getting CME hours, that helps us keep track of attendance and justify the cost of AV equipment and food and keep these presentations going, so please sign in. Today it's my pleasure to introduce Dr. Angelica Johnson. She's one of our third-year pediatric residents. Dr. Johnson joined us from Drexel University in Philadelphia, where she earned her MD, and she's going to West Palm Beach to practice urgent care / emergency. Dr. Johnson has no conflicts of interest, and today she's going to talk about an emergency department topic, the role of Pediatric SANE. So please welcome Dr. Johnson.
Hello, everyone. Good afternoon. My name is Angelica Johnson, and I am going to discuss the role of the Pediatric SANE in the emergency department. So I have no financial interests at all, and no conflict of interest whatsoever. So why did I choose this topic? I chose this topic because back in September and October, I did the 43-hour didactic lectures for the actual Pediatric SANE. I didn't finish the full actual going through and getting the exam part finished, but I did do the lectures, and I really enjoyed it. I wanted to bring it back, my learnings back, to show everybody what it means to actually be a Pediatric SANE. I thought that it was a very important topic, specifically because we don't get as much child sexual abuse or child abuse teachings here in residency or in medical school. So I kind of wanted to bring it back for us to all kind of learn and to be established in this topic. So in this presentation, I'm going to give a brief history, a brief overview of child sexual abuse. I'm going to give a history of SANE programs and the pediatric SANE programs. I'm going to talk about the effectiveness of SANEs, and I'm going to discuss how SANEs help the ED. So what does it mean? What does child sexual abuse mean? According to the World Health Organization, this is the involvement of a child in a sexual activity that he or she does not fully comprehend and is unable to give informed consent to. The child is basically not developmentally prepared, and it just violates the laws of social taboos of society. And this establishes that this could be a child versus an adult, or a child versus a child, and if the child is greater than 4 years older than the other child. Or this could be with a child or another child, and by age or by development, that they're just not quite fully developed. They're not fully developed, so therefore the other child has a role of power over of the younger child. So it basically must satisfy the needs of the person who is actually performing the abuse. Basically, they coerce the child to do whatever they want to do, some unlawful sexual activity. They exploit the child to use in prostitution or any other practices, and they use their pictures in porn. One thing I wanted to bring up is that child sexual abuse, or sexual abuse in general, is not necessarily just one topic. It's a spectrum of topics. It can range basically from less intrusive to the most intrusive, with kids just having photographs taken of them versus kids having actual harm done to them, a traumatic experience done for them. So it's kind of important for us to kind of keep our haunches up when we have kids who come in to us and they just state that they had this done, and we don't necessarily see any type of thing on the physical exam, because a lot of the time these kids do not present with a positive physical exam. So some characteristics of child sexual abuse is that physical violence is rarely used. So majority of the time you'll have these kids who present to you and you'll have a completely normal exam, which is, again, it's pretty common for this to happen, because a lot of the times it's not necessarily that they've been touched or traumatically abused. It's mostly that they've had a picture taken of them, or they've been told that they needed to touch something that they shouldn't have been touching. This often occurs over many weeks or even years, and this is frequently occurs as repeated episodes that become more invasive with times. And then a lot of times is a known or trusted caregiver. One thing that I read a lot about when I was doing my research is that these kids go through an episode of grooming.
Would the owner of a white Dodge Avenger parked at the loading dock please move your vehicle? Would the owner of a white Dodge Avenger parked behind at the loading dock please remove your vehicle? Thank you.
So they go through an episode of grooming. So the trusted caregiver or this friend of the family actual groom the child to doing what they want them to do. So they don't necessarily, they start off small. Basically, they have the child come over and just sit beside them, and then they eventually work their way up to something much more intrusive, which includes touching or photographs. I also wanted to mention that kids are inherently trusting by nature. So if your family, if the mom or dad trust this friend, the kids have no reason really not to trust this person as well. So it's easier for a trusted friend or a trusted caregiver to come and take advantage of this child. And this happens frequently as well, because majority of the time when the kids come in for some type of child sexual abuse, it's a person that they actually already know, the family knows. It is not necessarily one of the most traumatic event that we usually see on the TV. It's more so a person who came in and they did something to this child that has caused this child to go through this experience. Usually it's a male that commit the crime, but lately there's been a rise of females actually committing child sexual abuse as well. It's apparent, especially to other females. There's a recent study that says that in the past that there was about 2% of females that were committing these crimes, and now it's increased to about 6%. So, and that's within the last 10 years. Boys are reportedly less victimized than girls, but there's a worldwide focus that boys are also underreported mostly than girls compared to girls. Boys tend to, especially in families that believe that boys need to be boys, so boys usually are ashamed to come out and say that they've been victimized in this way. Boys usually try to keep it to themselves. It's different between younger boys versus older boys, especially with older boys. Older boys do not come out and say that this has happened to them. But younger kids, they usually come out and say things, but older boys don't. Another thing that I wanted to mention is that adolescents usually cause 20% of child sexual abuse. And again, that number is on the rise as well. Within the last 10 years, it rose up to 20%. Prior to that, it was about 10%. So how do these kids present to the provider? So he or she has made some type of statement of abuse, or the abuse has been witnessed personally by a caregiver or a provider. They were brought by social services or law enforcement for a non-acute medical evaluation. And a non-acute medical evaluation means that the abuse happened more than 72 hours ago prior to them presenting to the provider for an evaluation. They were brought after a suspected episode of an acute sexual abuse for a medical evaluation. And an acute, again, is less than 72 hours. The caregiver or other individuals suspect abuse because of behavioral or physical symptoms. A lot of times these kids go through regression, so they'll go through enuresis or encopresis, and they have normally been able to sleep throughout the night without having any bedwetting episodes or any stool episodes, and now they're not having that anymore. Or they start having some more emotional breakdown compared to what they were having prior to this, that they're crying more, or they can't go to a particular room of the house, or they can't go to somebody's, or they feel like they just are inherently distrusted of a person that they usually trust before. And then they're brought to a pediatrician for a routine physical exam, but during the course of the exam, the pediatrician noticed that there's some behavioral or physical signs that sexual abuse has occurred to this kid. And this means that the kid is showing some type of symptoms to this pediatrician that it makes the pediatrician just become a little bit extra cautious. One thing I did want to mention is that these kids have like a variety of complaints, and a variety of different things and we as pediatricians must keep our eyes open, because they don't necessarily always present to us saying that somebody came and hurt them or somebody touched them. So we have to make sure that we keep our haunches up and try to make sure we get the little small details so we don't miss these type of things. Worldwide demographics. So there is, for child sexual abuse, there's 18 to 20% affected are women, and for men it's about 8%. And then, but in a different report, there's about 8.4 to 67.7% of females to 3.8 to 35% of males have been sexually abused. And the reason why there's such a wide range is because throughout the world, each country has their own different definition of what it means to be sexually abused. A lot of countries, countries don't necessarily think that child brides are considered sexual abuse, but that was talked about that they won't report those situations to the government compared to the kid actually got traumatically abused. So most of these reports were discussing that a lot of the times the traumatic abuse is what usually gets reported, but the non-traumatic abuse is not. So the marriage, or they were just touched, because a lot of times they'll say that it was mostly that the person was just giving them a friendly hug, or they'll say that they weren't necessarily meaning to do that. So they don't necessarily believe the kid, and they don't necessarily believe that it's child sexual abuse, but in reality it is. There is approximately 1% of children who experience some form of sexual abuse. And then the sexual victimization of 12 to 25% of girls and 8 to 10% of boys usually occurs by 18 years of age. In the U.S., there's an estimated over 600,000 victims of child sexual abuse each year. And again, that ranges from the most traumatic to non-traumatic events. So what exactly is a SANE P? SANE stands for Sexually Assault Nurse Examiner, and the P stands for Pediatrics. But it's a registered nurse who's completed specialized training so that the comprehensive care of a sexually assaulted victim can be performed, and it's usually in ages less than 12, but each region has their own kind of age cutoff. I've seen a range between 12 and 14, but I think the general consensus is for ages less than 12. And for ages greater than 12, then you'll hit to the SANE A, which is the adult adolescent SANE. In addition to them actually talking to the patient, they do a forensic exam, and they can give an expert testimony that can kind of help get these kids taken care of. There are currently over 600 SANE programs in the United States, and there's over 2,600 SANE nurses in the United States. A competent SANE, so a good SANE, will assess the patients for an acute healthcare needs, and they'll provide consultation and provide stabilization for the treatment of the patient. A good SANE will also work with the patient to make sure that they're as comfortable as possible, to make sure they're not overly traumatized from just having to come into the emergency department or coming into a house to actually get the exam performed. They work in conjunction with the law enforcement, attorneys, CPS, and others. They try to help with streamlining the process as much as possible to make sure that everything kind of goes according to plan and to get whoever needs to be caught. So history of SANE programs, they were developed in the early 1970s. The first actual SANE program was developed in Memphis, Tennessee in 1976. But the reason why they were developed was because there was concern about care and safety of sexually assaulted victims. There were a group of nurses who noticed that a lot of not necessarily children in this case, but a lot of sexually assaulted victims come to the emergency department and wasn't receiving the care and proper exam that they should have been getting, nor was there proper documentation that was performed, and so a lot of the people were kind of getting off with things that shouldn't have been getting off on. So they wanted to come up with a a way to actually treat these kids and to actually care, not kids, but to treat these people who have been hurt and to care for these people who've been hurt and to do it in a formalized way. There are initially the SANE programs were slower growing, but there were two significant events that helped with the SANE program development. One being in 1992, the International Association of Forensic Nurses was formed, and the second was the forensic nursing was recognized as an official nursing subspecialty by the American Nurses Association in 1995. And the reason why these two are so important is because this led to kind of protocolized events, and they led to protocols, they led to people actually taking the nurses very seriously, because initially it was hard to get prosecutors to take these nurses seriously because they had been used to dealing with physicians in the past and they weren't necessarily experienced with dealing with nurses actually coming in to do official testimony to these people. But when they standardized these programs and when they actually developed protocols, then they had people come in and say, okay, let's start taking them seriously and let's actually start making sure that we can work with them a little bit better. The first certifying exam was done in 2007 for Pediatric SANE, and the first for the SANE A was done in 2002. So officially, SANE has been in here. There have been SANE since the 1970s, but for testing purposes, there has been an official certified SANE since 2002 for SANE A's and 2007 for SANE P's. So how do you become a SANE P? So there are three components to becoming a SANE P. There is the didactic lectures, there is the clinical component, and then there's the certifying exam. So there's about 40 hours of the didactic coursework. When I did the didactic lectures, it was about 43 hours, and that was spanned over 2 weekends. There are the clinical components. It's not necessarily hour-based, but it's mostly based on competency. You have to have a trained or certified SANE sign off on each exam that states that you can actually become a certified SANE prior to you actually going through and taking the exam. So the didactic coursework needs to be done prior to the didactic and the clinical coursework need to be done prior to actually taking the exam. You must get certified every 3 years, and you can, once you take the initial exam and you become certified, your actual clinical coursework can be used to carry over to make sure that you stay certified and you can continue to be certified every 3 years. Of note, there are more SANE A's than there are SANE P's, and the reason being is because there are more adults that are sexually assaulted compared to pediatric patients that are sexually assaulted. Some of the important courseworks and topics that are talked about in these lectures are mostly how to talk to law enforcement, how to give a testimony, how to take pictures, because forensic photography is much different than taking regular pictures, how to actually do the full exam. So when we did it, we went over how to, top to bottom, how to do a physical exam, including a full genital exam, how to recognize the difference of the different types of hymens and what is actually considered abnormal for a hymen versus what is considered normal for a hymen. We went over how to talk to law enforcement, and we had actual law enforcement agents come in and talk with us and teach us how to give good testimonies, so that way we don't kind of blunder on the stage. We talked about how to actually take evidence and how evidence should be properly stored, because there's a specific way that you have to take each and every swab, and a specific way you have to make sure that they undress, because they don't just take off their clothes. You have to make sure that they take it off piece by piece, standing on a piece of paper, and making sure that you collect every little bit of particle or evidence that they take off, so therefore it can be put into a brown paper bag to be delivered to the forensic unit. They talk to us about ways to talk to these families, and how to basically converse with these people about what the exam and what everything will be properly done, and how we should talk to the families about getting them tested for STIs and getting them tested for pregnancy and all the prophylaxis that goes along with that. But it was long, but it was rewarding, because you get to learn a lot to become a SANE, Pediatric SANE. So we're going to talk about actual effectiveness of SANE. And in order to do this, we're going to take a look at 4 different categories, which includes medical effectiveness, the psychological effectiveness, the forensic portion, and criminal justice portion. I tried to choose bigger studies because there are smaller studies out there, but I tried to choose the bigger studies that kind of hit on each of these 4 categories. Also, there are not a lot of studies that are dedicated to just pediatric SANEs. There are studies that are mostly dedicated to SANE A's, but there were some, and I found them. So medical effectiveness. So this is a study that was done by Bechtel. This was a study that was performed at Yale back in 2004 to 2006 over the course of 2 years. And at this study looked at children who were less than 14 who were victimized and they had a history of sexual assault. And these all included an acute exam. So anything that was the trauma happened less than 72 hours prior to them showing up to the emergency department. They looked at the implementation of their own pediatric SANE that they put into place. So they put this into place around 2005, at the end of 2005, the beginning of 2006. The paper didn't give us an exact date, but they said it was sometime between the end of 2005 to the beginning of 2006. And so they compared different portions between implementation of a SANE versus how it was done before. And before it was done primarily with just having the emergency room physician along with the resident go in and to actually perform the exam to go in and perform the exam. So the factors that they looked at was that did they have a history of sexual assault? Did they have a GU exam and GU injury, and was it properly documented? Did they have STI testing? Did they have STI prophylaxis? Did they have pregnancy testing? Did they have pregnancy prophylaxis? Was social work involved, and was they actually referred to a rape crisis center? Couple key things that I wanted to point out is that we can't see. But a couple of key things that I wanted to point out is that so if you look at the first slide, the first line that the injury documented, so if you look at after the SANE, there was more of the GU injury documented compared to before the SANE. But if you look at evaluating, it was interesting that there's one thing that I found really interesting was that they actually saw that they evaluated more for the STIs after the SANE, but the syphilis testing, for some reason, they both were even. And so I don't know why, and they didn't comment on the paper why syphilis was the one primarily that they tested for, and they didn't necessarily test as much for the other ones prior to the SANE and after the SANE. They had a good prophylaxis for gonorrhea and chlamydia, but not necessarily for pregnancy prophylaxis and HIV prophylaxis. And then it was pretty equal on them getting the social work evaluation on board, but referral to a rape crisis counseling center was a lot more heavily focused on, and after the SANE was implemented compared to before the SANE was implemented. Some of the problems with the study was that this was a retrospective chart review, and with that being said, it was hard to kind of say that the reason why that a lot of the GU injury wasn't documented was because they didn't have the actual injury, or maybe the physician documented it somewhere else and it wasn't necessarily where it needed to be. But so that was kind of hard to say. This wasn't blinded. This wasn't a blinded study. So eventually, and a lot of these charts were handwritten, and that's what they mentioned here in the paper, was a lot of these charts were handwritten, and they said that maybe they were seeing things that the SANE did because they knew that it was the actual SANE handwriting that was performing these exams. They said that maybe that a lot of times these these patients and their patients' families actually flat out refused the exam, and it wasn't documented in either charts if the patients they wanted to refuse the exam, and that was something that they wanted to say about better documentation. And then sometimes they said that maybe the SANE was just kind of overestimating the actual injury that the patient actually had. But overall, you do see an improvement of numbers, especially with injury documented and prophylaxis, and an actual referral to a rape crisis center. So psychological. Basically, this is a combination of studies where these are adolescents and patients and families giving their experiences of how they felt when the SANE was actually, doing what they needed to do. They felt that, the SANE was actually pretty sensitive to their physical and emotional needs throughout the exam. They were compassionate, caring, and personable, and they believed and validated their accounts of the assault. One thing to keep in mind that these people have been through some of the worst traumas of their life, and they have fears, self-doubt, and distress throughout this whole process, and then it's made even worse when they have to go to an emergency department to get this exam done, and then they're told that they have to take off their clothes and to actually go through the exam. A lot of the kids, and I saw this repetitively through these studies, is that the actual SANE made them comfortable by talking about something that they actually love, or the SANE made them comfortable by just not talking, because it allowed them to zone out. They didn't zone out to the point where they couldn't give consent, and that's very important because the adolescents need to be able to give consent throughout the whole exam. They didn't zone out to that point, but they zoned out because, they were able to actually just get through the whole exam, give their consent that it was done, but they just didn't have to necessarily continue to talk and to continue to relive and experience the trauma that they've already been through. And so I did read that a lot of the families said that the SANE actually kind of talked to them very well and put it in layman's terms and made them a lot more comfortable in actually going through the exam, and made them feel like it wasn't necessarily another traumatic experience that was going to happen to my child, but it was mostly to kind of just help get whoever I need to help do whatever I need to do. So forensic evidence. This is a study done by Horner et al. This is another retrospective chart reviews. All of these are retrospective chart reviews because it's very difficult to necessarily get a SANE program in place. So most of these studies that I found were all retrospective chart reviews. But this was one that was done at Nationwide Children's from January 2004 to January 2007. They looked at 464 cases, but only 343 were included because 127 were not tested. 127 of the kits that they performed were not tested due to basically either somebody recanted, the person admitted to it, or then they said a couple of them actually got lost, which is not the best thing in the world. But they looked at it. They looked at this at the ED and their SANEs. They looked at the ED and their exams prior to implementing their pediatric SANE program to after them implementing their pediatric SANE program. So they noticed, there's a couple of things here. They noticed that the first one, which was the positive forensic evidence kit, that there was more of the SANEs who actually had a kit that came up positive, or a kit that had positive tracings on it compared to when the pre-SANE was done. So they said that it was likely that the SANE collected the evidence in a way to actually keep the kit intact compared to what the pre-SANE had done prior. The DNA from the perpetrator was actually collected more in the SANE after the SANE was implemented, and again before the SANE than prior to before the SANE. Again, this is likely due to the way that the kit and the collection and that evidence was collected. And then again, I'm going back to this the genital exam physical finding, because it's very important that it's documented correctly, because they don't use pictures on the stand, but they use your words on the stand. And so if it's documented correctly, then it's able to provide exactly what happened. And so they really want to make sure that it's actually documented appropriately. And so if we look at it at what the SANEs had done versus the pre-SANEs, it was mostly documented in the SANEs compared to the pre-SANEs. And then they stated that even though there was like better documentation in the post-SANE compared to the pre-SANE, there was mostly about the same of them. There was indicted versus found guilty. They think that it's due to maybe that it was a physician who was actually giving the evidence versus the nurses giving the evidence, but they don't know the exact cause of why that was the case. But there was like no statistical difference that was showed between the charges filed, not charges, but the ones that were indicted for versus the ones that actually pled guilty, or found guilty. And then criminal justice. So this is a study that actually kept coming from all my readings. This is a study that actually kept coming back and back and back to Rebecca Campbell, the primary author of this study. She had done a study prior to this one that was much smaller than what this one was, and she wanted to redo the study to make it more nationwide. And the reason why is because she couldn't find any nationwide studies that showed that there wasn't evidence that sexual assault nurses actually did have an outcome on criminal justice. So she decided to do this study, and this study was referenced a lot in a lot of the readings, and so I wanted to find a study to present it to you guys, because it is one of the turning studies that I saw. But this was a national multi-site wide study, and it was examining whether it was whether having a SANE implemented into the program was able to actually have an effect on the outcome of the criminal justice case. So they found 6 programs. So initially they had invited 700, but 63 programs expressed interest, and then 30 actually completed the full application, and then they found 10 programs that were actually eligible, and they based eligibility on readiness, and readiness by using this readiness for organizational learning and evaluation instrument scale. And readiness in this case means that the organizational resources were able to there were enough organizational resources that them implementing this program wouldn't compromise their own operation. So they found 10 that were actually ready, and then they chose 6 programs. They chose 2 from the rural, 2 from urban, and 2 from suburban programs. And then they reviewed their files to find eligible cases, and they recognized that in order for them to have like a good power of 80%, they needed at least 0.8, they needed at least 35 cases from each site to have a power of 0.8. So things that they looked at to find the eligible cases is that the patient must be 18, they must have had a complete forensic exam and evidence collection. The evidence wasn't de-identified, and the patient actually made a police report, and it must have had occurred within this country. So what they found is that certain sites only did the pre and the post, and that was one thing that they weren't. Certain sites only did the post, and they didn't present their pre and post findings. So that was one thing that kind of made this study a little hard to implement, but they did state that Individually, each site did not have an improvement of rates. Individually, each site showed that it was no change, there was no statistical difference. But once they combined each site, they found that there was a statistical improvement. So they found that 86.4% is 86.4% were not referred or not charged, which is still a fairly high number. But when you look at the charge, but later withdrawn or they were acquitted, that went down to 4.2%. And then you saw ones that they were acquitted, and that went up to 9.4%. So they did show that it was effective, but they couldn't show that it was effective or statistically significant with each site separately. They had to combine the sites. Of note that even still with the implementation of a SANE in these programs, a lot of these kids, they weren't, or a lot of the evidence, they wasn't referred or they weren't charged, which is still pretty high pre-SANE versus post-SANE. And so they were trying to figure out why that was the case, and they couldn't give me from the paper, they didn't give an effective answer for why that was. Again, individually, these sites, they had significant findings, but they didn't have significant findings, but when they became together, their power increased and the findings became statistically significant. So we saw an increase in case progression post-SANE. We saw more cases were moving forward through the system, and they were reaching higher levels of case disposition. So pediatrician knowledge. Basically, child abuse education has been mandatory in pediatric residency since 1997, and it's always been a mandatory part of PIM education. But child sexual abuse is not necessarily a mandatory part of residency. So you get a couple of didactic lectures about child abuse, so you may get 1 or 2 lectures about child sexual abuse, but it's not necessarily a formal part of residency education. So it makes a lot of pediatricians, and we don't, and looking at it in the past, you don't necessarily learn how to do a full exam. So a lot of the pediatricians, they don't feel comfortable doing this and they refer out. And it's the same when you get to emergency medicine, not necessarily PIM fellows, because PIM fellows actually, which PIM is pediatric emergency medicine, but PIM fellows have to actually go through and learn the full forensic exam for most programs. It's not required at all, but for most programs, they have to learn the full exam. And so they feel a little bit more comfortable with doing this. But it's not necessarily a mandatory part of emergency medicine education. And so a lot of people just don't feel comfortable with doing these comprehensive exams. I tried to look up how the pediatric SANE was in relation to the child abuse physician, and there really wasn't any studies. I thought it was okay for them to say that the the emergency medicine physician versus the SANE physician were not equal, or just in general pediatricians, they weren't equal, which of course they shouldn't be equal, because the SANE actually had to go through this whole training and all of this stuff. But I wanted to see how they actually did versus a child abuse physician. Were they equal in efficacy? Did they actually document the exams properly? Was there better forensic outcomes with a child abuse physician versus a forensic nurse? But there are no studies out there that have compared the two at all. And I likely think that's probably due to, again, that maybe there's not enough child abuse physicians out there to actually go through a full study with this. But that was something that I would like to see in the future. So how does the SANE-P actually impact the PEDS emergency department? They basically help streamline the process, because these exams can take like an hour and a half, 2 hours, and to have the to have the emergency physician pull out from seeing their other patients to actually doing these exams is a very long process. The SANE P knows what's in those forensic boxes, and they know exactly what to pull out and know exactly what to swab and how to actually do it. And so it kind of makes the process go a little faster and a little bit more efficient. They provide quality care. A lot of patients like the way that the SANEs talk to them compared to that they felt. I did see something that they liked the SANEs and how the SANEs talked, and then they compared compared it to prior to implementation of a SANE program, and they said that they felt a little rushed when it was just a regular physician doing it. But again, the physician is taking care of the whole emergency department, so it's kind of harder for them to actually do a full SANE exam. A full forensic exam. And then the SANEs are actually they're cheaper than child abuse physicians. So in order to hire a full child abuse physician to come in to do all these exams would be expensive. The average child abuse physician, I looked it up, makes about $150,000 a year compared to a SANE, which is a lot more compared to what a SANE would make. But it does make, so they streamline process, they provide quality care, and they're a little bit cheaper than a child abuse physician. So I wanted to kind of just touch on SANE Ps in our area and what's been going on here, because I did do that didactic session earlier on. I did contact Judy McClintock, who was the person who kind of helped with navigating our SANE program here, and so they just got approved for a HRSA grant, the Help Sarah grant, and so they're trying to implement more pediatric SANEs in this area. So they have 3 nurses scheduled to go to Birmingham within these next couple of months in order to get officially SANE trained and to finish off that whole clinical assessment, because we don't really have anybody in this area to actually do the clinical or to teach nurses how to do the clinical assessment. So they're sending their nurses to Birmingham for training. They just recently finished training 9 RNs for SANE A's. And again, the SANE A's can go down to age 12. And then they have another upcoming 40-hour didactic session at the end of June, beginning of July. And they have a conference, they have a conference coming up in Kingsport, and then they actually have like a preceptorship checkoff coming up as well. So they're trying to implement this program here in this area, and they're trying to work with Ballot in order to implement and to develop a program for the surrounding areas. They just recently also have like a house they're trying to make it a centralized system for this area, so a lot of people can call directly to the house to request the on-call SANE and to see if they can actually help with getting them going to wherever they need to go. Problems that exist with this is that Ballot spans a fair amount of counties, and Ballot also spans 2 states. So each state forensic exam is completely different. Like Tennessee forensic box is different, way different than the Virginia forensic box. So it's taking a little bit of time because it's hard to try to figure out which rules and which regulations and who they should call and who they should figure out to call. So, but she's working on it. So in conclusion, we went over child sexual abuse, what's the SANE and the SANE P role and effectiveness. I want to shout out, say a special thank you to Dr. Mills and Dr. Brown, because they actually read through and helped me go through a bunch of stuff and answered a lot of my questions. I also want to say thank you to Dr. Judy McClintock, because she definitely sent me some stuff and sent me some information, and she was the one who actually, sent out an email initially at the beginning to tell Dr. Mills to say, hey, you're going to go to this program. So thank you. These are my references, and are there any questions? Yes.
I thought that was an excellent presentation. I just had a question about what's the ideal kind of structure of a SANE program? For example, in this system, would we have the Nusswonger PCD have nurses with SANE training, and then have the region refer to Nusswonger, or is it is this something that would be intended to be at larger academic centers or more distributed?
So the golden way that they would like to see these is that there would be 24/7 SANE coverage. The problem with that is that in order to get 24 SANE coverage, you need to have enough nurses that are SANE trained, and that's really hard to have for ballot, because ballot expands a lot of counties and a lot of in 2 states. So they're trying to work on making sure that they could have a centralized system, so they can have 2 people on call maybe at once, to see if they could send off to wherever they need to go. Because what happens, because they were trying to figure this out too, should they send these kids to Niswonger in order to be tested, or should they keep the kid? But the problem is that if you send the kid to Niswonger from Virginia, that's about an hour and a half away just for one exam. Would it be easier for the nurse to go up to Virginia, or to have a nurse who lives closer to Virginia to actually just go up and do the exam? That would be ideal, but again, it's based on how many SANEs that we actually have in this area and how we have to figure out coverage for the area. Because it'd be hard for that nurse to just continue to just do Virginia all the time without getting any supplemental help from all the other nurses in the area. And for her to be on call, for her or him to be on call all the time up in Virginia. So it's a work in progress currently. And so I'll keep you updated once I find out information. Yes.
With that in mind, is there any requirements either from a state, national, or just kind of local, region level of how kind of common SANE nurses need to be present for a particular area? Is there okay, we need to have this number or covering this region?
No, there's none, because we had for a while no SANE P trained nurses in this area, and so we still have no officially SANE P nurses trained in this area, and so we're getting some now, but there's no guidelines to say how many needs to be in the area. So according to the IAFN, which is the forensic nursing, but there's no official guidelines to state that how many need to be in the area.
What's our current process? We have a patient today. What is our process?
So our process is to have them examined by the emergency physician. And that really does depend on where they are, because if they are up in in the smaller regional hospitals, they don't examine the kids. They send the kids to Niswonger to have them examined because they don't feel comfortable examining. Or they call the police, and then they have, because this has happened before as well, they'll call the police, and the police will come up and do their own exam, which is, it's not the most accurate way to do things. But that's happened plenty of times where in the smaller areas they've called the police or they sent the kid to Niswonger. Any other questions? All right, thank you guys.